All right, let's jump straight in. Welcome to this explainer. Today, we're basically stepping into the shoes of medical detectives to decode a classic clinical mystery. We're looking at something that's incredibly common, yet surprisingly complex, and that's a simple red eye. I mean, have you ever woken up, looked in the mirror, and just seen this network of angry red blood vessels staring back at you? Most of us just brush it off, right? But what is that red eye actually trying to tell us about what's happening beneath the surface?
To really kick off our investigation, we have to ask this crucial question. What is your eye trying to tell you about the rest of your body? Because as we're going to discover from analyzing our clinical source material today, a bloodshot eye is rarely just about a lack of sleep or, a bit of dust caught under the lid. Sometimes it's a glaring red alarm bell for something much bigger and potentially far more dangerous happening deep inside your biological systems. And we're going to find out exactly how to read those signs.
To navigate this landscape, here is our roadmap for today. First, the red eye lineup. Second, cracking case 1. Third, treating simple episcleritis. Fourth, the rebound redness trap. Fifth, when scleritis gets serious. And finally, clues beyond the eye. Let's solve this step by step.
Okay, let's dive into part 1, the red eye lineup, identifying the culprits.
Just take a look at this overwhelming lineup of potential red-eyed causes derived directly from the clinical data. We are talking about everything from severe absolute emergencies like angle closure glaucoma to episcleritis and its much more dangerous counterpart scleritis. Then you've got your everyday culprits like conjunctivitis, uveitis, dry eye, a simple foreign body, or keratitis. It is an absolute alphabet soup of clinical jargon. When a patient walks into the clinic with a painful red eye, the doctor has to mentally sift through all of these suspects instantly, and they often present with incredibly similar outward symptoms, which really shows just how complex the eye is, making an accurate diagnosis an extreme challenge.
So how exactly do they do it? Let's move from theory to practice with part 2, cracking case number 1. Put yourself in the doctor's chair right now and take a really close look at this evidence. It's a severely inflamed, noticeably red eye, clearly causing the patient distress. Based on our source material, the clinician formulates an initial differential diagnosis, basically a short list of prime suspects. For an eye looking like this, the list includes conditions like episcleritis, a simple foreign body trapped in the eye, or perhaps an internal inflammation called uveitis. But just looking at the surface? Yeah, that isn't enough. We need hard clinical data. To gather those crucial clues, the doctor essentially has to interrogate the eye using a strict step-by-step examination process. Step 1 is measuring visual acuity, or VA. How well can the patient actually see? Has their vision been compromised? Step 2 is the slit lamp exam. This is basically a giant microscope for the eye, letting the doctor check for corneal staining, flip the eyelid to look for hidden debris, and check the anterior chamber for floating inflammatory cells. Step 3 is checking the intraocular pressure to rule out dangerous things like glaucoma. Step 4 involves dilation, opening the pupil wide to check for changes in the posterior or back of the eye. And crucially, Step 5 is checking the patient's medical history, specifically hunting for underlying rheumatoid causes. Literally, every single step eliminates a suspect.
After running through those rigorous steps and analyzing the data, we have a definitive diagnosis: simple sectorial episcleritis. Which brings us to part 3, treating simple episcleritis.
Now, what's really fascinating about the immediate approach recommended by the medical literature is that the very first line of treatment isn't a complex drug or some invasive procedure, it's bedside manner. The doctor is instructed to tell the patient in plain language, it's going to be okay, it will resolve by itself. Translating scary medical jargon into plain, comforting language is a vital, yet often totally overlooked part of clinical practice. The patient is stressed, they're in pain, and reassurance is just an incredibly powerful first step in the healing process. But for the actual physical symptoms, there's an escalating ladder of simple treatments to follow. First, ocular lubricants are used just to keep the eye comfortable and hydrated. Then, they recommend warm compresses. And I absolutely love the fascinating mechanics behind this. Our sources note that warm compresses actually work by overwhelming the pain receptors. It's this clever biological hack to trick your nervous system. Now, if the physical appearance of the red eye is a major concern for the patient, vasoconstrictors can be used to shrink those blood vessels. And if the pain gets truly intense, well, the doctor might escalate to non-steroidal anti-inflammatory drugs, NSAIDs, or a mild steroid drop like FML 0.5%. It's a highly targeted, very measured response.
However, right when the patient thinks they're completely out of the woods, we hit part 4, the rebound redness trap.
It's a sudden, unexpected complication involving a very common over-the-counter treatment that can completely backfire. It's a phenomenon called rebound episcleritis. This is a condition where the redness in the eye actually worsens after you stop treating it. Why does this happen? Well, according to the data, it's caused by the downregulation of alpha agonist receptors in the eye when stopping vasoconstricting drops like nafazoline. Basically, the eye's receptors adapt to the constant, artificial presence of the medication. The eye becomes chemically dependent on the drops just to look normal. This creates a vicious cycle where the cure itself literally starts driving the disease.
So the absolutely crucial point here is managing the jarring disconnect between what the patient expects and what actually happens when they finally stop taking nafazoline. The patient's expectation is naturally that stopping the medication means they are fully healed and getting better. The stark clinical reality, the eye is going to look significantly worse before it finally gets better. Managing that expectation is a huge part of the doctor's job, ensuring the patient understands the biology so they don't panic and immediately reach for the drops again, restarting the whole vicious cycle.
Let's see how this builds into something much more alarming in Part 5, when scleritis gets serious.
We are now elevating our narrative from the relatively mild surface-level episcleritis to its much deeper, much more dangerous cousin, scleritis. Contrasting these two conditions highlights exactly why an accurate diagnosis is critical. Simple episcleritis is mild, it usually resolves on its own, and the key treatments are comforting, things like lubricants and warm compresses. But scleritis, or related internal conditions like uveitis, are classified as severe and potentially sight-threatening. The medical response here has to be aggressive and immediate. We are no longer relying on warm compresses. We're talking about heavy-hitting medications like Predfor drops, atropine, and massive doses of oral steroids, up to 60 milligrams of prednisone, along with immediate referrals to specialists. It is a completely different, much higher stakes ballgame.
And here is a truly terrifying clinical paradox noted in the source material. If you have a red, painful eye, you might logically think that if the eye suddenly turns white and the visible inflammation disappears, hey, that's a good sign, right? Well, in severe scleritis, a sclera with no visible inflammation can actually indicate a significantly worse prognosis. Why? Because the lack of blood vessels and inflammation can mean dangerous scleral thinning. The tissue of the eye is literally wasting away due to a lack of blood supply, putting the eye at imminent risk of a catastrophic perforation. Sometimes, in medicine, a quiet, white eye is the deadliest symptom of all.
Which brings us to the ultimate twist of our investigation today in Part 6, clues beyond the eye.
If the eye is treating a localized problem, why on earth is the eye doctor suddenly referring our scleritis patient to a rheumatologist for systemic blood work? It's because scleritis is very often just the tip of the iceberg. Our clinical sources reveal massive, undeniable systemic links to conditions presenting in the eye. That severe red eye could actually be a critical warning sign for severe systemic autoimmune diseases lurking in the body, like rheumatoid arthritis, lupus, or sarcoidosis. It could point to hidden serious infections like syphilis, tuberculosis, or herpes. It can even be an adverse reaction to systemic drugs like bisphosphonates. The eye isn't isolated. It's quite literally a biological window into the health of your entire interconnected body.
Which leaves us with this final, remarkable thought to take away from today's explainer. If a single, isolated red eye can reveal a hidden autoimmune disease or a latent systemic infection, just how interconnected is your entire body? It really makes you marvel at the complex, deeply integrated biology keeping us alive and functioning every single day. Keep that incredible interconnectedness in mind the next time you look in the mirror. Thanks for joining me for this explainer, and always keep questioning the fascinating mysteries of your own biology.